If you could take your seats, we'd like to start this session, which is on spinal degenerative lumbar. We've got 8 papers, so it's going to be quite tight, 6 minutes, and then 2 minutes for questioning. Could we, I'm Richard Harker, this is Rohit Shetty, who will be moderating the session. Could we have our first speaker up, please? Have we our first speaker? Yes, excellent. Thank you. Do you want to introduce him? Yeah, just This is Luc van Dijk, who's talking about fusion rates of biphasic calcium phosphate bone graft.
Good morning, everyone. My name is Luc van Dijk. I am from the Netherlands, and today I'm going to present a study that investigates the efficacy and safety of a synthetic bone graft substitute, which was retrospectively evaluated in interbody fusion in a population from the United States. Disclosures, I work in the medical affairs department of said bone graft manufacturer. And the bone graft, the synthetic bone graft that is the subject of this study is calcium phosphate-based material, but it has a unique surface topography, so a needle-shaped surface topography. And preclinical research has demonstrated that this topography actually can make the material osteoinductive. So that means it can even form bone when implanted in ectopic sites, such as muscle tissue. And this naturally is considered to enhance its bone forming ability in various indications, including spinal fusion. As for this study, the study design, as I mentioned, the study was designed to retrospectively evaluate safety and efficacy of this graft for interbody fusion. It was a single center, single arm retrospective cohort study, and the indications were anterior lumbar interbody fusions, lateral lumbar interbody fusions, and transforaminal lumbar interbody fusions, which were either single or multi-level, in which this synthetic graft was used either on its own, so standalone, or combined with local autograft. So the outcomes were assessed radiographically on CT scans after 1 year, so 12 months, by an independent neuroradiologist who used a scoring system to identify or evaluate the presence of bridging bone in the interbody fusion. And for this, he used the scoring system, focusing either on the absence of cranial or caudal bony ingrowth, the presence of either a partial or complete bridging trabecular bone through the cage. And then score 1 or 2 were considered fused, score 0 was considered a non-union. On top of the radiographic evaluation, there was an assessment of clinical outcomes using pre-op and post-op visual analog scale for pain, so patient-reported outcome, as well as an evaluation of the adverse events. As for the study population, so there's an overview on the slide. So there were 55 patients with a total of 93 treated levels, relatively high BMI, 10% of them were smokers, and on the right-hand side we see the comorbidities. And as you can see, and considering this is a population from the US, there is a very high rate of comorbidity, so at least 50 or about 50% of the patients were obese. Almost 50% of them had prior lumbar surgery, and the list goes on. So there's lots of arthritis, heart disease, etc. And the mean number of comorbidities in this cohort were 3.3, so yeah, considerable number of comorbidities. Then the surgical parameters, so there's an overview here. Slightly more than 50% received an A-LIF, and then the remainders were T-LIF and laterals. And as you can see on the right-hand slide, there is a considerable number of multi-level procedures included as well. So it's quite evenly distributed from between single-level fusion up to 4-level fusion. So as mentioned, the fusions were graded on CT scans. So here we see some representative examples of either fused or non-fused procedures. So we see the bridging bone in the A-LIF, T-LIF, and lateral procedures, but also, for example, on the right-hand side, clear pseudoarthrosis in an L-LIF procedure, where we can see that radiolucency between the cage and the end plate. So here are the outcomes of the radiographic fusion assessment by the independent neuroradiologist. And as we can see, an overall fusion rate of 95.7% was achieved. And we also have some breakdowns of those numbers. So there is a fusion rate for the synthetic only, synthetic combined with autograft, and for the specific indications. And as we can see, yeah, the fusion rates are maintained to be high for all of these breakdowns, as well as on the right-hand side, if we look at the number of levels that were treated, we see a relatively high fusion rate in the single-level procedures. The multi-level procedures is two-level procedures 87%, and we see high fusion rate for the 3 and 4 level fusions. Then the clinical outcomes and complications. So the VAS improved by a mean of 25.10 points at 6 months follow-up, and there were some reported complications, but these were all considered to be attributed to the basically general consequences of the surgery, not directly attributed to the bone graft. So the conclusion of this retrospective study was that this synthetic graft was determined to be efficacious and safe, with a relatively high fusion rate and low overall complication rate and reoperation rate. Limitations of this study are obviously that there was no comparator. It's a retrospective study. That's it. Thank you very much.
Thank you.
Thank you. Any questions? I've got a couple. Just to clarify, you mentioned about the ALIF. Were they standalone ALIF, or were they augmented with a posterior? Was it a 360-degree fusion?
They were also instrumented.
Okay, so there's a 360. Yeah. And the second is, in terms of the graft surface area, when you all appreciate the fact that the surface area with an ALIF or a lateral interbody fusion significantly varies from your TLIF in terms of the approach-related access in the graft, how do you take into account that sort of discrepancy in showing that your results of TLIF are much superior to one of ALIF?
Yeah, that's a good question, actually. I think you can argue that with a larger area, it's easier to assess whether or not there's trabecular bone, whereas for a TLIF, you have a much smaller footprint. So I agree with you that's also complicating the fusion assessment. So I think that may be a limitation to combine these different indications in a single study, because obviously you will have, it's difficult to assess fusion, more difficult in the TLIF than in ALIF. So I agree with that. I think that's a good point.
Any other questions? Great.
Okay, thank you very much.
Thank you.
Thank you.
We have.
Thank you.
Thank you. Now, Leanne Wood's going to be presenting patients undergoing surgery for lumbar spinal stenosis with claudication and their surgical outcomes in the UK from the British Spinal Registry.
Thank you very much. So I'm going to talk to you about our study which looked at the British Spinal Registry data. These are my conflicts of interest. So this work has been funded by the NIHR for a program development grant. So to give you the context, so lumbar spinal stenosis, as we know, is a really big problem and has significant impacts on patients' walking ability. And in 2021, we did a mini audit of our service in Nottingham and found that around 60 to 70% of our patients were waiting over 2 years at that point for spinal surgery for spinal stenosis. And so this led to kind of the question of what are the patient outcomes for this patient group, given that they're waiting such a long time, and how can we really identify which patients are going to do best with surgery. So we thought that using the British Spinal Registry would help us to understand the characteristics of these patient group and also to try and identify what characteristics may influence success deemed with a minimum clinically important difference of 30% on the ODI. So we use people who are over the age of 50 years old, and we also asked for, because we are asked for lumbar spinal stenosis cases only, they have a field within the BSR that the surgeon classifies a patient for lumbar spinal stenosis or not. So we ended up with quite a specific sample. The BSR also obviously collects data on age, sex, socioeconomic deprivation through a postcode, BMI, comorbidities, and your patient-reported outcomes of VAS, ODI, and EQ5D at preoperative status, 6 weeks, 6 months, 1 year, 5 years, 10 years. And they also have surgical information regarding symptoms, diagnostic criteria by the surgeon, blood loss, surgery duration, whether they had a fusion or not, what kind of approach they've had, whether they had a spondylolisthesis or not, and whether it was a primary or revision surgery. They also included some things like complications and some patients' experience measures, such as, did you have enough information beforehand? How satisfied were you with your post-operative outcomes? Things like that. So for the 10-year period that we requested, only 7,000 cases, 7,247, were coded as having lumbar spinal stenosis by the recording surgeon, and 446 cases were excluded because they were younger than 50. Around 2,500 cases had purged follow-up data, so where patients had withdrawn from providing consent, which left us with only 2,528 patients who provided 6 months data, of which around 2,011 had complete data from baseline to 6-month follow-up. These patients were around 70 years on average, equally split between female and male, but there was a disproportionate amount of people who were from higher socioeconomic deprivation. So the sports cars, because they're more likely to be able to afford a sports car. They were predominantly primary surgeries, and most of them didn't have a fusion. So 75% had just a decompression on its own, but 58% of the sample had some sort of medical comorbidity recorded. And we compared our data set for the complete 6,801 sample to the people who gave 6-month data at 2,500, and there was no real difference between the two samples. At baseline, the average function was around 48.7 on the ODI, with leg pain of 7 and a VAS of 6 on the back pain score, and the EQ5D was around 56. So you can see these people had severe physical disability. And 6 months post-operatively, this came down to 29.8% on the ODI, 3 on the leg pain score, and 3 on the back pain score, and slightly improved on the EQ5D. Now, this is looking at a calculation of who reached the minimum clinically important difference on the ODI, and you can see 58% of people reached it for ODI, 84% for leg pain, 79% for back pain, and 47% for the EQ5D. So not everyone is benefiting from surgery as much as we expect from a functional point of view. And I think earlier the discussions have already raised that people don't tend to return to their walking function as we expect. We then looked at what are the patient characteristics that might influence this conversion. If you see the top squares up here, you can see that this uses as much complete data as we had, which is 1,957 cases. And baseline back pain intensity was the most significantly associated characteristic that made people more likely to not achieve the clinically important difference in ODI. So the higher your back pain score was preoperatively, the less likely you were to improve in your function score at 6 months. When we included all the surgical characteristics as well, you can see that baseline back pain intensity remains a significant predictor of not achieving clinically important difference. But also, if you have a revision surgery, you're less likely to achieve a clinically important difference. And if you had a fusion, you were much more likely to achieve a clinically important difference. We then also included people's 6-week PROM scores. So essentially, we've got your baseline kind of VAS and ODI scores, and their age and sex and BMI, etc. And then we included their 6-week change scores to see whether that made a difference. And you can see that it really did make a difference. So again, baseline severity of physical function was more likely to improve physical function scores at 6 months. But if you had worse back pain, disability, or leg pain scores at 6 weeks, you were less likely to reach a clinically important difference. So what does this tell us? When we compare the BSR data to other registries, we see that our patient cohort was slightly older than other registry data, and our patients had higher leg pain severity and higher disability preoperatively than other registers. What we found was that smaller proportions of our patients reached the minimum clinically important difference compared to other registers, and we also had higher rates of comorbidity, but this has been poorly reported in many registers around the world. And smaller proportions of those undergoing revision surgery achieved the minimum clinically important difference compared to those undergoing primary surgery, which is not unexpected and is in keeping with other literature. So what we did notice was that there's a mismatch with those who achieved a clinically important difference on function compared to those who achieved a clinically important difference in pain. And 6-week scores appear to be important with reducing the odds of achieving a clinically important improvement, which suggests that we could potentially target that with some physiotherapy or some rehabilitation to try and support people's early recovery. And other registry studies have also shown that there's a small component of people, so around 11% of patients have an overall poor recovery trajectory. So essentially we need to look at ways of how we can improve patient outcomes from surgery, such as providing some early rehabilitation to target early improvement. Thank you for listening.
Thank you, Jan. Any questions, Steve?
Stephen Vo from Health Sciences University. Hi, Leanne. Really interesting to see these data used, but I'm still worried about this stuff in terms of knowing what it really means without stronger case mix adjustment. And it looked like there's about 30% follow-up, so there's also lots of concerns about attrition bias. So I'm wondering what it really means.
Within our data, we did try and have a look at people who responded and didn't respond at 6 months compared to those who didn't. From a baseline point of view, there wasn't much difference between the two, which was interesting. We did compare, again, missingness across those who are having primary surgery and revision surgery to try and understand if that influenced the outcomes. And I forget, but I think that there was not much difference between those two either, certainly not on a clinically important scale when we look at it meaningfully. But from a case mix, it's quite limited in terms of, we've got this case that's lumbar spinal stenosis scored, and as Ashley had reassured me, these patients are most likely to have lumbar spinal stenosis because the surgeon has given them a diagnostic code of that. They weren't just lumbar decompressions over the age of 50 for any kind of leg pain or back pain. So hopefully that reassures us that these are the lumbar spinal stenosis patients, the truly stenotics.
One quick question, please.
Thanks for a wonderful presentation. I think the problem here lies that about a fourth of your patients have had a fusion. And lumbar spine stenosis are two different disease pathologies. Those who have a listhesis between the age of 50 to 60, 50 to 65, compared to those who are having multi-level decompression later on. And I think that may be related to also the fact that your back pain improvement scores is 79%, which is way, way over any other data that is presented in the world literature. So it may be misleading because surgeons and patients may look at this and say, oh, my back pain will improve, whereas stenosis decompression surgery doesn't do that.
We did control for fusion and spondylolisthesis within our variable models, and they didn't seem to have an influence on it, apart from the fusion, which obviously led to improvements in some of the presence of a fusion. It led to more likely achieving your physical function scores at 6 months, but spondylolisthesis didn't seem to have an impact.
Thank you. Thank you, Leanne. Thank you.
Thank you very much. Our next speaker is Rami Sharif, talking about enhancing surgical decision-making in lumbar degenerative spondylolisthesis, evaluating the UCSF, DS, and DSIC classification systems. Thank you, Rami.
Okay, good morning. My name is Rami Sharif, one of the spinal fellows at University Hospital of Wales. Thank you very much for accepting our project to be presented today. The study is about enhancing surgical decision-making in lumbar degenerative spondylolisthesis. It is a comparative evaluation of UCSF, DS, and DSIC classification systems. There is no relevant disclosure to this study. Introduction: the prevalence of lumbar spondylolisthesis is around 13% of the adult population, with the highest occurrence at the L4-5 vertebral level. The cost of surgery can vary depending on the specific procedure and the location. A standardized protocol for surgical decision-making has yet to be established. Modern classification systems aim to standardize surgical decision-making by predicting the intervention. So the objective of the study is to evaluate two classification systems to predict the appropriate surgical intervention and to improve the patient care. The first one is degenerative spondylolisthesis instability classification, which was published in 2015 by Simmons. It focuses on instability with 3 categories: stable, potentially unstable, and unstable. It links the radiographic findings to the surgical recommendations. The second classification system, which was published 2023 by Rangwala, by the University of California, San Francisco. It considered dynamic instability, sagittal alignment, and the clinical presentation of the patient. It focused on less invasive and patient-centered care. A brief description of the classification. The first one is DISC. It focused on 3 categories, looking at the low back pain, looking at the restabilization signs, looking at the disc height, the sagittal deformities, looking at the disc angle, and finally the joint effusion. And it proposed surgical approach for each one of them. The second classification, looking at 4 categories: segmental dynamic instability, 3 or 3 to 5 or more than 5, location of the spinal stenosis, and the sagittal alignment, segmental and global sagittal alignment. And again, the patient presentation, back pain or leg pain or both, and proposed surgical intervention for each patient. So the study design, we did retrospective analysis of 89 spondylolisthesis cases, and we applied the classification system to all of them. And we used the F1 score to assess the predictive accuracy of the classification. And we measured the alignment of the predicted versus the actual surgical intervention for each one of the patients. We found that USSF DS system had F1 score of 0.4, and it correctly predicted surgical intervention in 43 patients, 43% of the patient, and recommended less invasive procedure in 41% of the patients. The DISC had a lower F1 score, 0.37, correctly predicted surgical intervention in 37% of the patient, but suggested more invasive procedure in about 40% of the patient. For the F1 score, 1 is perfect, 0 is not accurate at all. The conclusion, takeaway from this study, USSF outperformed DISC in predictive accuracy and alignment with the clinical practice. The preference of USSF for less invasive surgery support cost-effective and patient-centered care. There were limitations of the study, retrospective nature with kind of a small number of patients, and we didn't look at the quality of life data for evaluating the long-term outcome. Future direction to incorporate additional parameters like comorbidities, functional outcome, and prospective validation to confirm the effectiveness in the clinical settings. Thank you.
Thank you. Any questions?
I have one. Would you use these systems to guide surgery for you or a family relative? And which one would you choose?
Okay. So it is a very tough question because all of my trainings, they said classification system doesn't work. Just go by your clinical judgment. But if the classification predicts the surgical outcome, I would go for it. For myself, to answer your question, I would go with the USCCF, the University of California. But again, it will not be the only factor for me to make a decision. It will be my clinical decision, discussion with the patient, and factoring everything to make the best plan for the patient.
And do you think that classification system is easy to use and definitely you can predict where you are?
I really hate paperwork, so I don't like to waste any time in my clinics just doing classification. But again, so we heard from yesterday about AI and predictive models, and this will help the AI to predict the case. And maybe in the future, in 10 years or 20 years time from now, the decision will be guided by the AI, and I will be the surgeon to do the work. I don't know if it comes or not. I don't know.
Thank you very much.
Thank you.
So we have Miguel Carvalho talking about sacroiliac joint pain treatment in a single center study.
Thank you.
He was quick.
Thank you. Good morning, everybody. Just to say, my name is Miguel Carvalho. I came from Viseu, Portugal. I'm very pleased to be here presenting this topic in this important conference. So I'm a consultant for SI Bone, and what I'm going to present here is our workflow, our treatment workflow in our department. We work in a multidisciplinary spine unit, and we see that SIJ pain is an important feature in our practice. We are very aware of this kind of pain, and we perform clinically all the procedures to effectively identify this kind of pain. And when we identify this kind of pain, of source of pain, we always do this stepwise approach. We start with conservative treatment with non-steroidal anti-inflammatory drugs and physical therapy. And when it fails, we start with anesthetic and steroid injections. And when it fails, we move on to PRP injection. And finally, when everything fails, we go to SI joint arthrodesis. So to assess these treatment options that we are doing, we just retrospective this retrospective analysis of this personal database in a private practice hospital, and we assess all these patients. When we contact them, and we contact all the patients that had some kind of invasive treatment, injection, PRP, or surgery. So in the contact, we had this questionnaire to assess the improvement. We did the EK5D questionnaire, and we assessed the satisfaction rate. So the results that we had is that for the 202 patients that we have identified in our database with SI joint pain, we have identified that 21%, 21% out of 900 patients with lumbar pain, which matches the literature. It's well known that this is the number between 15 and 40% of patients with lumbar pain will have some kind of SI joint pain. From these 202 patients with SI joint pain, we understand that 60 patients had conservative treatment, and they went fine. We just read out the clinical registers, and they were fine. There were no needed for further procedures. This was about 28.7%. The other 142 were contacted and were followed through, and with 37 patients, or 29%, just ended up with just a steroid injection, 47% with PRP injections, and 24% of these patients had to undergo surgical arthrodesis. So for the patients who undergone injection therapy with steroid and anesthetics, we had improvement in 64.5% of patients, with moderate, mild, or no pain in 90% of patients, but from these patients, 43.2% had moderate pain. So the large part had moderate pain. Despite this, we have a satisfaction rate higher than the improvement rate. For the PRP injections, similar results, with roughly 2/3 of the patients reporting an improvement, but those who are with moderate, mild, or no pain, nearly half of them have moderate pain. And once again, the satisfaction rate was higher than the improvement rate. For the arthrodesis, we have a higher improvement rates with a lower moderate pain end result, and a similar satisfaction rate. So, in the spirit of full disclosure, for the arthrodesis, we had 2 revision surgeries. We had 2 complications: one misplacement and one infection. Both of these cases were revised and with no sequela. 2 patients had an ALIF, an L5S1 ALIF, and 1 patient had, in the same surgical timing, a missed discectomy, and in 8 patients they have multi-level fusion in the same surgical time. So, the overall results are this one. You see that despite an improvement, but we have to see that these are the patients who were contacted, this as a last therapy. So anesthetic and steroid injection, we have improvement in 64%, but the higher rates are for the arthrodesis, and the moderate pain, the lower rates are for the arthrodesis. The satisfaction rate of the overall procedures are high because we believe that if we do a stepwise approach and if you explain this to the patient, they engage in this process, and so they fully understand that it can or cannot improve with these procedures, and I think this engagement can be worthwhile for the patients. So, in conclusion, the SI joint is the most effective. The SI joint arthrodesis, despite the fact is the most effective tool to SI joint pain, there is an important role for injection therapy. And the step-by-step approach is the most important thing for the patients, because they tend to give some importance to that and to understand their role in the process. Okay? Thank you once again.
Any questions? Thank you so much for making the effort of coming all the way from Portugal. So thank you very much. Any questions?
How do you differentiate?
Do you mind introducing yourself, please?
I'm Raman Kalyan from
Thank you.
England. How do you differentiate that the pain you get in the sacroiliac region or the buttock region is not a referred pain from the lumbar pathology? That's the tricky part of the diagnosis and indication. So I do pain diagram for all my patients with lumbar pathology, and in 70% of patients, even though they have a primary lumbar pathology, often have sacroiliac joint region pain.
Yes, thank you. Thank you very much for that question. It's very important. It's a very important question because of course, lots of patients does not have just solely pain from the SI joint, but they have also pain from the SI joint. We perform the provocative tests. As my clinical practice, I prefer always for all the patients that have lumbar pain, I perform the provocative tests for each patient for the SI joints. I find lots of patients that have pain from the SI joint, but lots of patients improve with medication. So we don't need to treat the SI joint because lots of patients will improve from the medication, such as the patients with lumbar disc herniation. They improve with medication. Also, so, and you know that roughly 20% of patients with lumbar disc herniation need surgery. The other ones just go well with physical therapy and medication. So for the SI joint is the same thing. We just do the provocative tests, then we treat them, and when the pain is persistent, then we try to use the injection as a diagnostic tool and treatment tool also.
Very quickly, 15 seconds.
Quick question. How sensitive do you think the Faber test is for SI joint dysfunction?
The Faber test, it's not very sensitive. I tend to use 5 tests in my clinical practice. I tend to use 5 tests. If just the Faber test is positive, I don't consider it as
What
an
5 tests are those?
I use the 14-finger test.
I think we can.
I use the straight.
Sorry, we can take this outside after this. We're just running short of time.
Okay.
Okay.
Thank you.
Okay. Thank you.
Sorry. Thank you.
Thank you very much for an excellent talk. Very interesting. Our next presenter is Michael McCarthy, who's comparing the radiation dose for L5S1 nerve root blocks between surgeons and radiologists in the private sector and NHS.
Chairs, ladies and gentlemen, thank you for having me. I'm Michael McCarthy, consultant spinal surgeon in Cardiff. I'd like to acknowledge Samantha, who unfortunately couldn't come today. She's done all of the work here and she's one of our medical students. For this talk, there's no conflict of interest. The background, well, a lot of us as surgeons do nerve root blocks for amyloid epidurals, and so do our radiology colleagues. In the private sector, we are all given badges that we have to wear, and they measure the radiation exposure to us. And IRMA guidelines, patients have their radiation exposures recorded as well. And the radiographers just kind of said, Mike, you and Stuart, your doses are really low. And I thought, okay, let's do a little study on this and just see what the difference is and why there could be a difference. And the guidance is that you should have doses as low as reasonably achievable. There are no guidance levels for facet injections or nerve root blocks or anything like that from IRMA, but there are national diagnostic reference levels, and that's for lumbar spine X-ray should be less than 6 grays. So the aim of the study was to compare our radiology colleagues, myself, Stuart, and 3 radiology colleagues doing nerve root blocks, both in the private sector and in the NHS. And in the NHS, we would also include trainees to see if that increases doses to patients. And the null hypothesis was, of course, that there was no difference between the groups. We identified 50 patients for each consultant in each sector. We then looked at all of the radiation doses. We looked at the diagnosis as well. We used lots of statistics. There was essentially no difference between the clinicians other than the spinal surgeons had significantly lower doses than the radiologists. We used ANOVA testing to test the groups. Average age was 60. We had equal split of male and female. Radiation dose was below the IRMA guidelines, which was good. The only major difference was between the radiologists and the surgeons. And the ANOVA table shows how they all interact. And this is the graph with the error bars for the radiation doses. So what you have is the surgeons in both sectors, with trainees as well, having far lower doses. In fact, the lowest dose of one of the radiologists was still almost higher than all of our average doses. And this is just comparing the 2 groups as a whole. And again, the dose is still just below that 6 grays. When we looked at pathology, there was no difference. When we looked at level, there was no difference. So the only difference was in the clinician themselves. So why would that be? And what Samantha did was she went in and watched us all doing the injections. And essentially, the surgeons, we take about 5 or 6 single-shot X-rays, and they're done by the radiographer, yeah? And that's that. Whereas the radiologists had their foot on the pedal, and they must have had a very heavy lead foot on the pedal. So they're more confident, and they screen the needles in. They continuously screen while they're injecting the dye in. Why they do that, I'm not entirely sure. Why we, as the surgeons, do it different, not entirely sure. But we've identified to the radiologists, importantly, that they probably need to reduce their doses by not doing that. So in conclusion, we still managed to have doses less than that of an X-ray, doing all of these root blocks, which is good. The radiologists possibly need to modify their techniques in line with the spinal surgeons so that they reduce radiation to the patient and to themselves. Thank you.
Thank you. Any questions? I thank you for the interesting. I've got a question.
Yeah.
Did you get a chance to look at body habitus?
No. But, so this was retrospective. But what you could do with regards to that is look at the MRI and subcutaneous fat thickness and distance, things like that. So you could do that. But with the numbers we've got, we will have covered all of those. It's a Welsh population, so the body mass will be slightly higher than in England.
I'm sure you'll agree with the fact that the body habitus in terms of the radiation would clearly be a contributing factor.
Yeah. Yeah. But I don't think we sent all of the larger patients to the radiologist because we didn't want to inject them.
Fair enough.
Thank you very much.
Thank you.
We haven't really got time for more questions, I'm afraid.
Perfect.
He's come through. Okay, let's
Come to present.
So Mike, I know, is a very skilled spine surgeon, but do you also find that the radiologists do CT-guided nerve root blocks?
Ah, right. So this is all just fluoroscopy. And clearly, some of them do the CT-guided ones. It depends on their training, and that's a different ballpark for radiation.
Yeah, sorry.
Great, thank you so much.
Could we have our next speaker, please, who is Christian Oasis, I believe. I might not have pronounced that correctly. It's modified Wiltshire approach and far lateral decompression for lumbar degenerative disc disease with foraminal stenosis.
So yeah, hello everyone. I'm Eddie. I'm on F2 at the Gloucester Royal Hospital. And today we're going to be talking about treating foraminal stenosis with this modified Wiltshire approach with a far lateral decompression. Now, we know that degenerative disc disease causes back pain, disability with a variety of different etiologies, but in this context, it's really foraminal stenosis that we're really concerned with. And it's been treated, and still is, many times with variations of spinal fusion. And there's two key downsides to fusions. That's a worse infection profile, especially in the context of implants and metal work if required, and adjacent segment disease, which is essentially a phenomenon of an accelerated rate of degeneration at the adjacent level to one that has been fused. So if you want to treat stenosis of the foramen and avoid the fusion, foraminotomy becomes a suitable option. And to just appreciate foraminal stenosis a bit further, here's just some sagittal CT slices with narrowing of the foramen. And if we look at the axial MRI, we can then start to appreciate the area of interest. And briefly going over this surgical approach, this is our target area. And just note the multifidus and longissimus muscles are very important to this technique. And essentially, we start with a central midline incision over the lumbar spine, then retract the subcutaneous tissue laterally towards the site of the decompression. And then once we find that border between multifidus and longissimus, which we would have measured beforehand in preparation for the operation through radiographs, we can then split that myofascial border between those muscles and get a direct view over the facet joint and the foramen to then be able to undertake that for menotomy, which usually involves taking away some of the ligamental flavor of this hypertrophy and the tip of the SAP to ensure that the spinal stability is preserved whilst decompressing the exiting nerve root. And here's some more diagrams to really appreciate how the process would work. Obviously, pre-op planning to know exactly what the culprit exiting nerve is and what we need to take away to decompress this. And then using fluoroscopy guidance to essentially mark out landmarks of the patients of what side we're going to be decompressing and the superior and inferior pedicles, like so in the dredging process. And central incision, retracting this laterally. And again, we know that distance because we've measured it beforehand with the radiographs. And then splitting that myofascial border between multifidus and longissimus to then get that view to allow us to actually take away, for example, any osteophytes in the superior articulating process and undertake our decompression that way. Obviously ensuring good hemostasis and closure of the fascia afterwards to avoid hematomas. Now, essentially what we showed is a 20-patient case series, all with MRI or CT proven foraminal stenosis that were treated by a single surgical consultant with the modified Wiltshire approach and foraminotomy, and according to the baseline PROs and post-operative at about 6 and 12 weeks to essentially see how they've responded to this. Bearing in mind the MCID criteria to make sure that any changes aren't just statistically significant, but also clinically relevant as well. And what we showed is that in all the parameters that we looked into, EQ5D, ODI, and VAS, there was not only a statistically significant improvement, but was also clinically relevant as well, above the MCID threshold. Complications-wise with this approach, we had no one required reoperation. There was 2 instances of a small dural tear, that was fixed with Duracell, and one patient had just a superficial wound infection that was managed with oral antibiotics. Now, despite the limitations of being a relatively smaller sample size and a shorter follow-up period of about 3 months, we can still see that the modified Wiltshire approach can produce good outcomes, at least in the short term, when it comes to foraminal stenosis. And the nice thing about using a midline incision is that we could use that same incision further on if we need to do a compression on the lateral side, contralateral side, sorry. Thank you.
Thank you.
Thank you very much.
Any questions? So can I just highlight something? So, so you showed an axial MRI scan and drew that box there.
Yeah.
That's partly the lateral recess. The far lateral component looked okay to me. I might have missed it. Correct me if I'm wrong.
Should we go back?
And then no, it's okay. And then the diagram which you drew was of foraminal stenosis. So you pick up a foraminal stenosis in the sagittal section. You pick up a far lateral component in the axial. So just a bit confused with that.
Apologies for the confusion.
Any comments? Any comments?
Hi there, sorry, Huilinke, I'm the senior author. Most of the diagnosis is actually based on the sagittal view.
Sure.
So, of course, you know, you get some information from the axial view, whether there's a far lateral disc, but actually the focus of the surgery is to move the tip of the SAP to make space within the foramen.
Sure. No, thank you. Thank you. Just asking for clarification.
Thank you.
Thank you.
All right, thank you.
Anindya Basu is going to be presenting on unilateral biportal endoscopic T-lifts, and is it worth undergoing the learning curve if you've already mastered tubular minimally invasive T-lift?
Thank you. It feels great to have come back to UK after 7 years. I did my training here. These are my disclosures. And if a patient like this, a 52-year-old gentleman, comes to my clinic in my hospital with complaints of left leg pain, radicular pain, claudication, failed conservative treatment, with an MRI like this, which shows instability and stenosis at the level of L4-5, would most likely get a surgery like this, tubular minimally invasive T-lift. This surgery is really fast in my hands. I can do this surgery in about 60 to 70 minutes if I'm not training any fellow. And I've done more than 350 of these cases since 2018. So time is changing, and people are just boasting their endoscopic prowess in social media. So I got confused, thinking that should I change my practice? Should I learn something new? And I decided it's time for a change, and I start doing endoscopic surgeries. So the basic concepts of unilateral biportal endoscopy is that it uses 2 ports. And actually, the concepts have been taken from knee arthroscopy and devised by a neurosurgeon who saw his orthopedic colleague working in the knee with the arthroscope and started this surgical concept. And actually, what we do is we work in the interfascicular plane between the 2 muscles of the multifidus. And the work is done by elevating the multifidus. And we work firstly in the potential space. The multifidus is not attached to the lamina. It lies loosely over the lamina, and the potential space is occupied by fibrofatty tissue, and we work in that space by elevating the multifidus. We don't damage the multifidus. That is why it is not damaging to the multifidus, and this is ultra minimally invasive. So this is the concept of UB. And is the shift too difficult? The answer is no, because you're working in the same posterior anatomy, and the standard spine instruments can be used, and that got me excited. So this is the setup basically present in every orthopedic unit: the shaver system, the drill system, the camera, and the light source. And you need the same Kerrison punches and the disc punches that you would use for your microsurgeries as well as for your open surgeries. So we looked at our data, where we looked at a total of 65 patients who had this surgery and UB T-lift and MIS T-lift, starting from November 2024 to February 2022 to February 2024, all operated by myself. And we included patients with grade 1 or 2 listhesis with a minimum follow-up of 3 months, and we excluded patients with infection, tumors, poor bone density, or with revision cases, or patients with tandem stenosis. And these were the parameters that we studied. We found that while looking at the results, our immediate post-op pain was less in UB T-lift compared to MIS T-lift. However, the operating time was significantly higher in UB T-lift, possibly because I was going through the learning curve initially, but now, also the post-operative hematoma collection in the drain was quite significantly less in UB T-lift compared to MIS T-lift. However, we had a failure of fusion. I'll discuss that case later. And this is a short surgical video where we can see that while we have put in the endoscope, this is the first view that you get after putting in the endoscope. You have landed in the Son space, which is a potential space. You have lifted up the multifidus. You have gone underneath the multifidus. The lamina is not the lamina, you're not hurting the multifidus at all. And with RF, what I'm doing is I'm shrinking the tissue. I'm shrinking the loose areolar tissue that is there in the sound space, and just enough to, to expose the bone. Till now, I was working in a potential space, but the moment I start drilling the bone, I start working, I'm making a trough, and I'm actually making a space that makes my life easy. So if you're hurting the multifidus by doing scraping of the multifidus before you start this step, you're not actually doing UB the right way. So once you've got this view, it is basically the same principles that you follow for any posterior spinal surgery. You try drill, try Kerrison punches to take away the bone. If you're doing a fusion, I use more Kerrison punches so that I can save bone for my fusion. And yeah, you've gone to the opposite side. I do all my bony work before taking out the flavum, and this is how I'm removing the superior articular process, inferior articular process with the osteotome. And then I go ahead and do my flaval work. I remove the flavum. The idea is to get a very good view of the opposite side lateral recess as well as the traversing root on the opposite side. So that is something which is very, very good in UB. And this is the next step where I start preparing the end plates. And this is this step. You can see such beautiful view I've got of the end plates. With RF, this is a real-time video where I'm using the RF. I've gone into the disc space with my endoscope, and I'm doing the end plate preparation right, under my vision with instruments without hurting the end plates. Whereas in MIS TLIF or microscopic TLIF, you can see in this video on the right lower part, it's basically a blind process. You cannot go, even with a pentero microscope that I'm using in this case, I cannot look inside the disc space and do a adequate end plate preparation like I would do in a UB TLIF. So this is the image after putting in the cage. Again, another issue is the posture of the surgeon. If I'm doing an MIS TLIF, I have to lean back while doing the contralateral decompression, whereas in UB TLIF, you can see that the posture of the surgeon and the assistant, I'm quite comfortable in my posture while operating. It's not working? Yeah. So these are the clear-cut advantages, out of which I would like to point out hydrodissection. The water actually does your job much easier by seeping in between the bone and the flavum, as well as in the dura. So you get to do the bony work very fast. And this is, look at this video, the amount of the excellent vision that you get of the opposite side, contralateral nerve root, traversing nerve root, and the lateral recess. I bet you can't get that video, that visuals with your microscope. So
30 seconds.
Yeah. So I think I'm overshooting my time, so I'll come to the conclusion slide. This is one of the cases which failed. Possibly I used the expandable cages, that's why. So in conclusion, the present study looked at the effectiveness of a relatively new technique, and it has a better, UB TLIF has a better short-term postoperative back pain outcomes, less collection in postoperative DEM, but has a longer surgical time. However, more studies are required to prove this. This is a slide I put in to show the differences with monoportal, but due to lack of time. Anyways, thank you.
Thank you. Any questions? Pretty much in terms of the theme, what we're discussing over the last 2 days sort of matches in terms of the learning curve we as surgeons sort of go through. And clearly what you're demonstrating is that, I'm getting better at it and I do it much more quicker with less complications. But in terms of your decision-making process, in terms of do you look at a particular individual, clinically match their symptoms to the scan, and then say which particular technique might be best suited for them? Or have you just converted yourself to do this and saying, this is where I'm going to stick to my practice and not go back to what I've been doing in the past?
Right. So between minimally invasive TLIF, tubular TLIF, and UB TLIF, I don't really, have a thing to choose at the moment. I juggle between the two techniques. If I've got multiple cases in a day, I'm rushing through the cases. I'll rather do a tubular TLIF because it's fast in my hand.
So it's timing,
yeah,
rather than a clinical indication.
Kind of at the moment, yeah.
Okay, thank you very much.
Thank you.
Thank you.
And now our last presenter, please, who's Anthony Sorrell, on development and validation of a tool for the measurement of the psoas muscle to identify potential sarcopenia in spinal surgery.
Hello there. This has been a last-minute substitution, so I'm actually Harsh Iqbal from Northumbria Healthcare. So I'm going to talk through our psoas spine study protocol. Essentially, we wanted to develop and validate a tool so that we could measure the psoas muscle to identify potential patients with sarcopenia. So, let me move on from there. Sarcopenia, I mean, I'm sure we're all aware now, it's an age-related progressive loss of muscle mass and strength. And essentially, it's a marker of physical frailty. The 2019 European Working Group, they defined it as probable sarcopenia being low muscle strength. And that's relatively simple to measure, but actually to confirm the diagnosis, you have to identify low muscle quantity or quality. And that's more challenging. You're looking at doing some further investigations with either a DEXA scan, bioelectric impedance analysis, or you're looking at cross-sectional imaging with a CT or MRI. So it really got us thinking, is there something that we can do to identify sarcopenia in our patients that's already there in terms of an investigation? So we know MRI is routinely used for our lumbar patients. Can we use this to identify, to assess muscle quantity, and is this related to postoperative outcome? Now, the potential radiological surrogates we were looking for, so we had to look through the literature, and we found transverse psoas muscle thickness, as well as psoas cross-sectional area as being validated measurements in other data sets. So we used those. That led us on to our aims for this particular segment. It was really to develop a standardized and reliable protocol, and also to see whether this assessment tool could be used by a multitude of subspecialties, so the radiology team as well as the spinal team, and at varying levels of expertise. The way that we developed the protocol was to discuss initially with the MSK radiology team to see what MRI slices, what would be the most appropriate, and what we found was that the L3 inferior end plate, the psoas was visualized quite easily on that, and that axial cut was consistently available across the trust. So transverse psoas muscle thickness is drawn out there. Essentially, it's the diameter of the muscle and perpendicular to the longest axial line. So psoas muscle cross-sectional area, however, is an outline of the psoas muscle there, and then using the PAC software to calculate this. That information was then translated into a document, to essentially a step-by-step guide, as you will, of how to perform this. And then that was distributed to the relevant parties that were going to look at the data. No further training was given to it, and it was a single-center study. That information was picked up from January 2016 to March 2023 across about 1,000 patients, and a subset of that was taken away for triple reporting with a consultant radiologist, a consultant spinal surgeon, as well as a trainee. The results from that showed that we had good reliability looking at the psoas muscle thickness of 0.793, and an excellent reliability when looking at the cross-sectional area of the psoas, 0.939. So essentially that gives us a bit of confidence that the way that we're measuring is a reliable method, it is reproducible, and is backed by the literature that we took it from. And the next step for us will really be, which we're doing just now, is multivariate analysis to essentially see what the association is between these measurements that we've taken and what the outcome from the problems will be. Of course, the final aim of it all will be to target these patients that have sarcopenia with prehabilitation, as we heard earlier on, to essentially optimize them for surgery so that they could get the best possible outcome as possible. Thank you.
Thank you. Any questions?
Thank you. So have you got the ongoing follow-up trial planned yet?
Yeah, so the multivariate analysis is already happening. So this was just the first step in terms of the overall study pathway. So we just did the validation, obviously presented that, but at this moment in time, the multivariate analysis is ongoing.
That's excellent. So we'll be hearing from you
Absolutely.
in future conferences. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you to all our presenters for keeping to time. We started a little late. We're finishing a little bit late. But thank you all, and stay for the next session.
Hello, everyone, and welcome. Hope you are looking for a feisty debate today. And BSR, the BritSpine registry, we've been filling the data from its inception on May 2012 now. I think the compliance rate is becoming better now. And we have a fantastic panel here to debate on it. What else can you ask? The BSR innovators, Lee Breakwell and Ashley Cole, sitting on opposite sides, one of them to say, and Mike Hutton, to start off the debate, followed by Irfan as well against it. Now, the BSR has been for the last few years, and we've been putting the data. And are we getting anything out of it? That's the main thing. Data is important. We need the data at this current time. So the big data and everything we talk about, the AI, what is the BSR doing to us? And by a show of hands, can I see from the audience, how many of you have accessed the BSR in the last 6 months to do an output data? That's quite a lot, or at least 30%, 40%, which is good. I expected much more less. That's fine. So shall we start with Mike to start for the motion that the BSR is actually doing the data properly? So Mike, can I have it?
Things take time to evolve. I just want to start with a really important notice, because I know some of you may be confused, but this is not the weight management for back pain discussion, in case anyone... I'm currently training for the Ozempics. Why are we here? This House believes that the British Spine Registry is it delivering data that we can utilize and use? Well, look, I just want to go back in time. It's really interesting for me. I've just gone some old slides, etc. Where did this all come from? Well, for those of you in neurosurgical, we had a disaster in orthopedics, which was called the 3M capital hip. What then happened was, as a result, a series of things, a lot of time before it was spotted and patients came to harm. This is not new. There's a whole of the NHS is in a bit of a shake-up at the moment, if anyone's just seen the news headline. But we've had these processes before. Darcy wanted data to compare people. We wanted revalidation for doctors. The Francis report in 2013 basically said we should be able to have data on our individual performance. We had our own things going on in spines, dynamic stabilization through the years. We put it in, we took it out. Listening to some of the talks in this conference, it looks like we're putting it back in again, right? So the National Joint Registry came about by then. We're behind them by about 10 years. But I tell you what, we are way, way, way further than many of the other specialties that exist. So the evolution of what happened with the British Spine Registry was in 2010 in BritSpine Liverpool. In one of these meetings, it was agreed amongst the group that we should have a working group where we would have our own registry. There were registries out there already. It was launched at the next BritSpine, and then we updated the platform, which I think became a lot more user-friendly, around 2016. And then because of a problem with compliance, Ashley and I fought very hard for a best practice tariff, which is now the envy of many, many, many other specialties, many specialties. And 2019, just so when you look at the data, that's the first year the best practice tariff was in place, and then COVID happened, and that has had a massive effect on British Spinal Registry data. So the first point I wanted to make is, this is not an easy piece of work. If you go through what's available to you and the stuff that's had to happen, okay, lots of people have put an awful lot of time into this. Some of them are not here, some of them are on the stage, okay? It's not an easy thing to suddenly get all the different forms of outcome scores onto a platform so you can use it the way you want to. Okay, we've designated what we want. Consent, all those things, they are not easy. We have a system that essentially now If you want to see your implants on the system, you just type in cages, and go and look, those are all the cages that are on the registry. And if you're a manufacturer, it's very easy for you to go and say, right, I've got a new implant, I want it on the registry, I'm just going to go there, tick what type of implant it is, and I'll submit it, and it's suddenly there for the surgeons to put on. This is where we're at. User data, right? There is, coming up to sort of 400,000 patients on there. Each of those will have designated pathways. The usage and compliance has gone up year on year, but look at what happened during best practice tariff, it jumped. And what drove that? Lots of things. You could see the compliance wasn't very good at this time. This is an old slide of mine of where we were. About 20% of lumbar spine surgery was hitting the registry, and we were still having our own problems with implants. And you could see that only 15% of implants were going on the registry, and we then made the same mistakes where some centres were putting stuff on and some weren't. We didn't know. So best practice tariff. So here we go. This is my first point of the day. To the opposition, right? This is the last quarter's data. If you scroll down it, if you're green or yellow, you're actually getting the best practice tariff, right, which is more than 50% of your cases going on there. That costs you 10% of what you would earn that quarter. Red, you're not getting it. Let's have a look at who's near the bottom. Irfan. Northern Care Alliance. According to you, you've had 1,200 cases, and you've not put any on the BSR. That's great, that's up to you, I don't mind. It really doesn't bother me. But that will have cost your trust. If they were just all discectomies, and I'm sure some of them were far more complex cases, for that is what you do, would have cost you about £1/3 of £1 million. Is it producing any research? Well, Ashley seems to think it's quite a good system. He's the chief investigator for this study. And it's an excellent study, and it's using the British Spine Registry to capture data. There's a pathway on it for it. And do you know what? He's not alone. There are plenty of other papers. I was actually quite surprised how many there were as I went round. This is all from this morning, just working out what is going on. So, yes, it is being used. But what if research is not for you? What does it do for you? Well, do you know what? It allows you to review your own practice. And you can run a revalidation report when it's time to revalidate. You get a pretty good idea of whether you are helping patients. This is all my data. I normally show Mr. Orpin's back in 2016, but he got upset about that, and I understand why. So, performance against my peers. Can I do that? Well, look, this has just been run this morning. Yes, I can. I can go down there, and I can have a look and see, for a microdiscectomy at 6 weeks, okay, how do I compare to other surgeons? Am I, the same as other surgeons? It's as simple as that. And I think, yeah, we can make these better. These have been around for a while. But I can generate that report there and then and put that as part of my appraisal and just look at it whenever I want to. That's me, the green dot. I can use it for things like, I can use it as a tool to consent patients. What are the chances of me being better, the same or worse after this operation? That's a really powerful thing. Visual description, you come out with a figure. Some people just don't quite get it. But I can actually show them my data now, because I've got enough of it, and show them this tool that goes, if you have a back operation, you're a red dot as a patient. If you're in the green zone, you're better. The further to the far green corner, you are really, really good. And if you're red, I'm sorry, you're worse. And if you're just a bit grey, I think you're probably not that better, are you? Guess what? Showing all that data reduced my indemnity costs with the underwriter by 10%. I'd love to know how many of you in the room have done that. Implant surveillance. The registry data is already being used with these institutions. Okay? It's going to get even busier. The Outcome Registries Programme and the Medical Device Certificate at the MDOR, it's all part of law. And we've already started to use it and ask companies to start looking at their data. We need to get it better. I'm not saying there's always room for improvement. So let's look at this. Seriously. Really? Do we not believe that it's delivering data? Of course it's delivering data. It's how we use it that's important. And I would suggest what we should be debating is not whether it delivers data that's usable, but what we are going to do for the future. We've already had talks on AI, and I would suggest it's the future we should be concentrating on. Thank you.
was excellent, Mike. I hope Ashley comes up with some more music there. And is it going to be music to the ears for all of us and to say it's only numbers? Or is he going to fight out Mike or succumb to him?
I didn't know you were allowed music. That wasn't in the rules of engagement that I wrote. It's just not fair. So I'm going to tell you that the British Spine Registry is not achieving useful, usable data. I have some disclosures. So what have we achieved with spinal data so far? Lots. Look at what we've done. We've done lots with NHS data, awesome amount of work from mainly Mike, for all the GIRFT work, model hospital, dashboards, and now NSIP, which, if anybody's not used NSIP, is amazing. I know Mike's going to talk about this in a few minutes. But it isn't BSR data. So I look at this all the time, all these other data, but it's not BSR. It's different. And yes, I agree with Mike. The number of patients has gone up year after year after year. We're putting in about an extra 40,000 patients onto the British Spine Registry every year. But compliance is such a problem that our data is not generalizable. And this is our problem. And this is the same data that Mike scrolled through. So this is compliance for the first 3 quarters of the current year, financial year that we're in. And I've just split it into whether you achieved 75 to 100% of the cases on the BSR compared to HES data, which we think is accurate, or whether it was less than that. And you can see that only 32 providers are achieving 75 to 100% of their cases on the BSR. And 21 of those are private. And then down the bottom, we've got 74 providers who are in the 0 to 24% range. How can we be achieving useful, usable data when we're there? Well done to those with excellent compliance. These are the NHS trusts who are achieving 70 to 100% currently. Well done. These are the big trusts, more than 500 cases already this year, with compliance less than 15%. Our results are just not generalizable. So in those trusts, their average compliance is 7.5%. Mike says we've achieved a lot with registries so far. I say we haven't. It was launched in May 2012. I completely agree with that. But if you do a Medline search, you'll find 12 peer-reviewed publications. To me, that's 1 a year. And even the European and the Nordic registries will agree that registries haven't really had a significant impact on quality of care. Now, that's not a criticism of the British Spine Registry. It's maybe just a criticism of registries in general. So what Mike and I do agree on is that it's time for the BSR to change. We need to revise it pathway by pathway. Define a core data set. Define those confounding variables, the things that make a difference to the outcome, that will mean that our observational data is biased, and then the statisticians can allow for that. Define some specific RCTs, and yes, I've got an RCT in the registry, all right? And observational studies as well. I love observational studies. Improve compliance. Even if it's only in specific hospitals, I think if we get to a stage where we have 50% of the hospitals putting in 90+% of the data, we can at least say it's generalizable if we look at just their data. We need to improve the support of the consultants putting data in. And they will then get their individual compliance will be on NSIP. So when you go into your NSIP platform, you will see your compliance, your own personal compliance, and that will be great for your appraisal. And as Mike says, we need to be providing data for ODEP and beyond compliance so that we can make sure our implants are working. I think we've got work to do, but I think we can do it.
Thanks, Ashley. Now, the other co-founder for the British Spine Registry, he's going to say, no, it's all not like that. And back again, like what I said. So I invite Lee Breckville to give his view.
Thank you, everybody. So it's a long time since I've stood here brainwashing you all and hammering you all about the registry. I personally have no direct involvement with the registry anymore, other than I'm a user. Obviously, sit next to Ashley in our offices, and we talk constantly about it. But so I'm not actually directly involved, other than through the BSS. So just to reiterate something that Mike said, really, in terms of why did we do the BSR and why was it decided by the society. So as he said, in 2010, there were lots of problems, lots of political issues starting to come to a head. The government was taking more interest in what we were doing. And at that time, Ashley was the BAS audit lead. And so we put together the audit for 2010. And apparently in the UK, there were 237 microdiscectomies performed in the year up to 2010. Or at least that's what the audit said. And basically that was mine and his and our colleagues, because we were the only people who got an email into the office the week before the audit was presented. So it was clear we weren't anywhere near knowing what was going on in the UK. And that was essentially why the registry was set up. Michael's already covered this, that you can get a lot of useful things out of it. One of the things I've taken to my appraisal is the friends and family test. Whether it means anything is debatable, but if you look at the quotes, there's some really nice comments that you can take to your appraisal. You can work on your own personal practice in internalising that, which is, of course, important. But there's lots of useful data that you can pull out if you use it. You've seen this graph already. This is from the 2024 annual report, showing that we still grow at 40,000 cases a year, as you've heard, and that there are active users still using the registry regularly. So again, great. Thank you very much, everybody. So I'm going to speak specifically really about the registry from a BSS, Scoliosis Society perspective. As the incoming president, this is important to me in terms of where can we take the registry. As my colleagues have already said, it's not perfect. We don't use it anywhere near as well as we would like, which is painful to us as those who've worked hard on it as a machine. And so I'd encourage people to stick with it. And this is where we're going with deformity. So this is just an age demographic of patients on the deformity pathway. And as you can see, the pediatric population is heavily subscribed in that. These are the cases on the spine deformity pathway. And like Ashley, I can't read from that distance. So we're on 40,000 cases in the spinal deformity pathway. But just look what's happened when you have somebody like Ashley leading on a trial, embedding it in the BSR, and look at the cases of the BASIS trial. And that's all of you out there. So the BASIS trial has been very well supported. But look how quickly you can capture really quality data just by using a motivated set of people in a well-designed form. So well done to everybody. And that's a sign of what is possible. We have been going for 13 years, and there is a bit of a drift on some of the other aspects. So the BSS has set about making some changes to our pathway that we can get more quality data out of what's already in there. So we're making some changes. So the agreed plan is to have two types of pathway within the deformity world. So there's a BSR Lite for those people who just want to do clinical practice, aren't interested in research, aren't data nerds like those of us sat on the desk here, and just want to enter their operation. So there'll be a slimmed down mandatory data set. And then there's the BSS, as in the British Scoliosis Society, study group, which is being set up to look at more specific research questions and embellishing the data capture. And that will be a choice at surgeon level. So that's down to us as the clinicians. So the BSR Lite will enable us to streamline the process and improve compliance and give, as I said, a smaller, tighter data set. Really quite minimal. Basically, type of deformity, procedure performed, the implant utilised and any complications, and then linked to auto-proms. And as you know from the BSR, a lot of this is done for you by the system. As opposed to if you're a member of the BSSSG, it will allow detailed data collection for institutional and multi-centre research, and you can then conduct proper trials from that data. There will be things like BASIS, which has proved that it's possible, observational studies for ODEP, as Mike has already said, and beyond compliance on specific implant-related questions. So, for example, there will be different work streams within the BSS. We can look at the paediatric world where we might have a separate pathway for early onset, including some of the more syndromic type of scolioses, adolescent idiopathic, clearly our bulk volume specialty, and kyphosis and spondylolisthesis. As you all most certainly know, BAS and BSS have been working for a number of years on an adult spinal deformity pathway, and that will have a separate work stream with specific questions based on that. One of the things we didn't do in the early days, because this wasn't really an accepted thing, was set up a data dictionary behind the registry in the first days. And so to align ourselves with international registers, that is now being done for deformity pathway. And then that allows data validation, allowing you or us as the society to do individual or system-wide audit. And the study group will define study targets for inclusion for you as an individual to be an author. So if you submit enough cases on AIS, you can be on the papers relating to AIS. As we've heard, there's a lot of achievements. We've got a long way to go, and I'm positive about the spinal deformity side of things, that we are going to take what we've learned, where our anxieties are, that we can improve. But there are over 385,000 patients, as you saw. There are nearly 500 active pathway owners. That's you as the consultants, as well as our delegates, as well as our juniors, as well as our admin support teams. The BSR has become very much part of the vernacular. It's just said as a throwaway line, the BSR, all the time in meetings like this. And I'm very proud of what we've all done in achieving that. And there's a whole generation, or indeed 2 generations, of trainees who've graduated through the system, where the BSR should and hopefully is part of their life. And it's exciting to translate the data into future evidence. So I would just say thank you all for your commitment, and please stick with us. Thank you.
So now back again, Irfan, to show that it's not delivering any useful data, it's all numbers. So Irfan Siddiq.
Thank you very much, Pal. So I'd just like to start with a bit of history. If this works. So Thomas Percival, a link to Manchester. Back in 1803, he suggested that it's not sufficient for us to just follow established practice. We've got to look at outcomes, we've got to reflect on our own interventions and amend accordingly. I think there's no doubt that the BSR is a very significant achievement, and credit to Ashley, Lee and Mike for getting the BSR to where it is today. It really is probably the outstanding achievement and contribution to spine surgery in the UK, certainly since I've been a consultant. However, there are concerns, and what I'd like to put forward is my perspective and my thoughts on issues with the BSR and registries in general in spine surgery. Firstly, spine surgery is unique. We can't compare it, in my view, to knee surgery, to cardiac surgery, to vascular surgery. There's a whole array of issues around collecting data and analysing data in spine surgery which aren't adequately taken into consideration when we do analyse our data. Simply put, surgical goals can vary, so we can do the same procedure in a number of patients and have completely different objectives, whether that be relief of symptoms, whether that be partial relief of symptoms, for example, leg pain versus back pain, whether it be stopping a patient from deteriorating, whether it be to prevent deterioration in the future. And without considering these goals when we're analysing data, we're really producing misleading outcomes. There's a whole array of conditions that we treat, there's a whole array of approaches, there's a whole array of techniques, which I think is way and above what we see in any other speciality. So we're not able to apply standardized outcomes when we're looking at our data. Knee surgery, very straightforward outcomes, pain, mobility, revision rates. We're looking at a lot softer outcome measures, which then are more susceptible to inaccuracies. How do registries tackle this problem? Well, they basically, so British Spine Registry, other spine registries, what they do is they look at data or collect data in a condition-specific way. It can be condition-specific, procedure-specific, goal-specific in order to eliminate those issues with analysis. The problem then is you have a very highly complex data set which becomes difficult to analyze. You then stratify it, and by stratifying it, you diminish numbers, and as soon as you start performing surgeon-level analyses, they almost become irrelevant and inaccurate, certainly. There are issues with surgeon-reported data. There are major limitations with and variability with what surgeons report, as, for example, what complications are actually complications. There's variations in, for example, reasons or indications for revision surgery. This is all published and well known in other registries, but I think it's particularly relevant to spine surgery. Just by way of example, the state of New York started to publish raw data on cardiac interventions back in the 1990s. Initially, it was just pure, plain raw data by institution, by surgeon. Very quickly, they found that the surgeons were becoming risk averse. They were avoiding high-risk cases, referring on to colleagues in other centres, diminishing delivery of care. They then risk-adjusted outcomes, published risk-adjusted outcomes to try and counter that, but then found that surgeons were upcoding patients, so attributing confounding variables where they didn't exist, gaming data in order to improve their analyses. The issue with risk adjustment in spine surgery is that it's much more difficult because we're dealing with softer outcome measures than total knee replacements or vascular surgery. There's many more confounding factors, many of which we don't even measure. So to try and formulate a risk-adjusted analysis is incredibly complex and then again compromises the outcomes. There's issues with patient-reported outcomes. They're fundamentally flawed, and this is well documented. There's a recall bias. Patients just don't remember the level of symptoms that they had preoperatively and therefore diminish their outcome accordingly. There's over-reporting of complications. This is a study that we did some time ago. Surgeons tend to under-report complications. Patients tend to over-report complications. The truth tends to be somewhere in between. There's something called a response shift phenomenon. So this is, again, published upon and well documented, particularly in spine surgery. And it's the moving goalpost. It's the patient who comes to you preoperatively complaining that they're unable to walk, and then postoperatively complaining that they can't play football. So that you're dealing with an internal change in the patient. Their expectations change. The other issue is the impact of the timing of PROMs. So the further and further away you get from the surgery, particularly in spinal surgery, the question is whether that PROMs is actually a reflection of the surgery that you've undertaken or whether it's a reflection of the condition itself. The counter-argument is, well, all these factors, all these things that I mentioned affect all patients, so surely they can just be ignored. But that's not quite right, because as surgeons, our case mixes are very different. We have surgeons who are high volume, low complexity. We have surgeons who are high complexity, low volume. We need to consider that when we undertake these kind of analyses. Even surgeons who carry out similar complexity of procedures, the patient populations are very different. Do we consider things like socioeconomic status, smoking status, when we're evaluating outcomes and surgeon-level results? The issues about surgeon-level analysis is quite significant because potentially it could affect anything from career progression, reputation, revalidation. So without it being done in a nuanced way and given in the right context, it can be quite misleading. So my question is, as surgeons, is this data sensitive for us? Is it considered safe? Well, it's not actually, because under GDPR, UK GDPR, this is not sensitive data to us. It's sensitive for the patient, but it's not sensitive to the surgeon, despite its potential implications. So it's not subject to the same safeguards. Overall, I think there needs to be a balance between transparency. Surely patients need to have access to information on outcomes, but at the same time, there needs to be fair representation. So in conclusion, I think the BSR has made fantastic progress. Credit to the people on this panel. But I think significant issues remain. And I think until these are addressed, I think it can't be considered truly useful and usable data.
Thank you, Irfan. I open the floor to the audience to ask questions to the panelists.
Hi, so I'm Sleiman Haddad. I'm from Barcelona. I work in the European Spine Study Group, and I wanted to give some comments. So I understand that the BSR has multiple objectives. One of them is research, and I'll be handling this part. So for data to be useful, it needs to be representative, and representative of the practice, meaning compliance, and representative of the pathology, meaning granularity. However, increasing granularity and increasing follow-up would inevitably reduce compliance. And therefore, the only way to handle this is having dedicated local research staff and ultimately channeling local resources for this staff. So the first limitation is and will always be the human factor. The second limitation is the infrastructure itself. So the granularity of the data will depend on the dimensions that you are capturing. And as the BSR is now built, it will capture the ones that we have now. And however, as you are increasing the number of patients, there will be a point where if you add 100,000 patients more, it will not add to the quality of the data you have. So this is where I recommend to include, for example, raw radiological data into the database itself. And even though we do not have the tools now to analyze them, the tools will be coming in the near future. And this will increase the value of the BSR, not only for research, but also for the industry itself, and attract capital to be invested in it.
Do you want to comment about that, Lee or Mike?
I mean, I agree. The big problem about putting images on there is that you enter into a different level of data governance, and that's the big problem. It would be fantastic to be able to do that, but then and I see your reasoning why, because at some point you may be able to look at a whole group of patients with a whole group of implants and see what happened. So it's a good idea. And as I said, you know, what we need to do is think about where we go from here. And I think everyone's saying that, really. We all agree we've got to a point. I do think there's usable data on it now, but we've got to look at the future with AI and stuff like that.
Yes.
Hiya. So I don't disagree that the registry is a good thing and useful, but I work for one of the regional spinal networks, and all the regional spinal networks in the country have been told the managers can't have access because we're not surgeons. We therefore can't share any of the data between our centres to look at the practice, because the data is only available to surgeons and their people that they agree to have access. So our research officer within the regions can't look at this, we can't produce it, and we can't share it with our patients because of the access. Is that going to be looked at any point?
I'll say that one. Yeah, yeah, you're correct. But the British Spine Registry has never denied a request from NHS England. And we're currently working with NHS England on a very recent request, and we've turned that around within 2 weeks. Get NHS England to request it. If they want regional spinal network data, we'll have to produce regional spinal network data, but there has to be some investment from NHS England to produce that. It's quite a complicated thing to do. But I agree with you.
I thought people will be queuing up to ask the panelists questions. I can't see many people standing up. Oh, Tim, yes. And before that, yeah.
Hi, Matt Newton-Eade from Birmingham. I've got no conflicts in this. It's somewhat of a selfish question, but I suspect it might apply to others. Our trust previously bought Amplitude from the manufacturers of BSR, and there was some kind of handshaking that went on. We're now moving to a different platform developed by Mike Reed up in the north. It's called Staircase 13 or something else Orwellian. And the question for the panel is, for those people whose trusts are moving to some kind of, off-the-peg database, how do you foresee that interacting with BSR or whatever? And you may not know the answer, in which case I go back to my trust and say, you've got rid of amplitude, I'm just going to stick it straight on BSR.
Yeah.
Very rambling, but thank you.
Sorry, I'll get that as well because I'm lead. What your trust did was they bought a package called Enterprise, which basically means that they've got a version of the British Spine Registry that is separate from the main BSR. But all that data feeds back into the main version. All right? Yeah. So it's just a way of your trust effectively linking their PAS system to the enterprise version so that they can import patient demographics. But other than that, it gives them nothing.
And we've now jettisoned amplitude.
No, amplitude. It's the enterprise version. Amplitude is just a data provider. They're our data processor for the BSR, and so they've got rid of enterprise. But the BSR still exists on any web browser. So you've all got web browsers. So you can go into the BSR and enter your patients just like any other trust would who doesn't have enterprise. Does that make sense?
Yes, it does. Thank you.
Yeah, brilliant.
Tim?
Yeah, I'm Tim German from Plymouth. Thank you very much to everyone who contributed to the debate. It wasn't as contentious as it maybe could have been because I think there was broad agreement that there's plenty of scope for improvement. And I think the question is, really, how do you improve it? What do we want out of the registry? Because I think at the moment it's trying to be many different things. And my underlying concern, I think I share with Irfan, really, that if you really want to change things, you have to have good quality data. And if you try and collect good quality data on absolutely everything, you'll collect poor data on absolutely everything. And I think we really have to decide on what we want to achieve. And one of the biggest problems is a lack of a denominator for most things. For example, many outcome studies really aren't relevant unless you know the patients that didn't have surgery but could have done, possibly. So I think we're not going to decide it today, but I think it seems there's an appetite to discuss exactly what we want to do and whether we want to focus on specific questions or whether we want to just churn out data, which I think it is very difficult to know what it means.
Anyone wants to answer for that or for the comment?
I would agree entirely with what you said, and I think Ashley and I would always accept that we struggled with exactly the things that Irfan described, is the complexity of what we do. You do the same operation for 5 different conditions and you do 5 operations for one condition. How the hell do you measure that? I think we did probably set out to try and do all things for all people rather than focus, like the knee ligament registry did 1 operation. We didn't agree with that, but it is what it is. So all I can say to him is that's exactly what we're trying to do within the BSS. So the Scoliosis Society has a relatively niche area of work, and we are going to try and hone down and focus on a handful of operations within our field to improve the quality of that data. So I would agree. And it's beholden upon BAS and the subsections within BAS to look at the different pathways in the same manner.
Okay. One question?
Hi, I'm Tony Isaacson from South Tees. I'm a bit embarrassed to admit it that we're not doing well with compliance in the BSR data. So my question really is, what is the difference, or what are the sort of things that have been implemented between the trusts that are doing really well and putting loads on to people like us? And how do I get myself to that point, really?
There's 2 things, really. Money is the #1 driver. If you look at the big... But no, hang on. If you look at the number of cases you do, and as I say, most... If there's a discectomy, there'll be scolies in there, etc. They pay a lot more money, but I'm just taking 10%. That gives you a rough idea of how much you're losing per quarter. So that drives a huge discussion with your trust. If they realise they are losing, and you're quite a big trust, a lot of money, then that allows for us, how are we going to sort this out? And that's where we were at. And the next thing you know, you've got lots of people helping you run the data, collect the data, chase the patients, and you see improvement. So that's the first thing. The second thing is I think what we're talking about. If a clinician sees something coming back to them as an improvement and actually sees the benefits of what they're doing, then they'll do it. if it's just an extra add-on task of 1,000 tasks that they're having to do during a busy day, then they won't do it. But I would say money's been the main driver. The best practice tariff is, as I said, people are very jealous that we have one.
Okay. Unless there are any more questions, because we have for time, we'll wrap it up. But thank you very much, all the four of you. And I think the conclusion is, yes, we have usable data, but how we use it, it's in our hands. And we have to still put all these data. There is no question about it. And we continue to do so with some improvements in future. Thank you. Thank you very much.
Okay, so a quick political update session. So if everyone grabs the seats again, stays here, we're a bit behind, so we'll try to whiz through. Ashley's going to talk again about the British Spinal Registry, which he doesn't believe in, and update us on where it is.
Yeah, it's a bit bad, isn't it? Okay, I get that. Yeah, I have split this talk up into lots of different sections, so this is the last section. So this is a little bit of an update on the registry. By the way, for those interested, the 2023 and 2024 reports have been signed off and they will be on the website very soon. As we've seen, patients are going up 40,000 a year, and likewise the forms that are completed by clinicians and patients. But this is the key. So if you want to collect PROMs and PREMs on your patients, you need an email address. And I think you can see from the data there that we're getting better year on year, but if we look across the whole database, we've actually only got 52% of the patients with an email address. No email address, no chance of a PROMs, unless you still do paper. The update on the outcome registries program is positive because nothing's happened for 10 months. There is a new NHS England National Clinical Audits and Registries Strategy Development Programme, which has started about 3 or 4 months ago. And at the moment, NHS England is working through the contracts it has with NHS-funded registries. So we're kind of at the bottom of the to-do pile, and it's a big to-do pile. However, trusts now have a legal mandate to send all their implant data at unique identifier level to the Outcome Registry Programme, the ORP. I'm not sure they're all doing that, but they have a legal mandate to do that. And of course, those implants will include spinal implants as well as everything else like pacemakers and other devices. We've been told that the BSR can have this data from ORP. So at some stage in the future, we will have device data at unique identifier level. We don't have it yet. So for now, we're still collecting basic device implant data, just manufacturer and name of device. And this is, of course, to support ODAP and beyond compliance, which Sachin is going to talk about in a minute. So I wanted to run through the spinal deformity pathway revision, because this is a print and repeat, all right? We're going to just do it in exactly the same way for every pathway. Firstly, minimum data set. This will include things about the diagnosis for the patient and the procedure. We're going to keep it simple. Everybody will be pleased about that. But we're going to consider the likely analyses that are going to take place. So again, we can think about the high volume stuff, complex stuff, and we need to be consistent with the international spinal registries. Right? This is a group of registries that have all come together. We're one of them, and we need to make sure that we match their minimum data set as well. As I say, we'll be collecting implant data. It needs ultimately to be at unique identifier level to satisfy medical device regulations, and it must include attributes. So things that are likely to affect outcome, like what a cage is made of. And to allow for, and again, this is all to allow for device monitoring, which we've been through. So if we go back to our deformity pathway, This is our core set for adolescent idiopathic patients having scoliosis. So we need radiological correction data, and that was a question we were asked earlier. We need PROMs and PREMs, and the decision's been taken from a very good COMET initiative. I don't know whether anybody's familiar with COMET, but they basically define core outcome data sets to collect from patients. You do a literature search, you do a Delphi, and you work out what items you should collect. And this one, for adolescent idiopathic scoliosis that Marinus did a few years ago, suggests we should use SRS-22 and EQ5D for our adolescent idiopathics. Job done. Global assessment of outcome and satisfaction. Complications. Now, at the moment, we collect intra-operative complications very well, I think, but I'm not sure we collect post-operative ones very well. Revision surgery. If the data goes in, it's there. And we're going to throw in an inpatient one for quality of recovery 15. All right, and there's a reason behind this, which I'll come to in a minute. For non-adolescent idiopathics, we are going to put in CP child if the patient's in a wheelchair, and early onset scoliosis questionnaire for those under the age of 10. And the aim of the registry, the deformity pathway, will be to run multiple studies. RCTs, observational studies, but this will be the aim of this pathway. We have a priority setting partnership already, so we know what patients want us to find the answer to. We have good PPIE, patient public involvement and engagement, through the Scoliosis Support and Research Society. So let's start with some experimental studies. Registry-based RCTs, right? They're good. They're the same as any other RCT, you're just using the registry to collect the data, which means that you can then go on and collect long-term data 10, 15, 20 years down the line, as long as the patients are consented. And obviously, BASIS and BASIS 2 are the two examples in the registry already. Anybody heard of cohort multiple RCTs? I'm sure people will have done. So this is clever. This is a cheap RCT. And the way you do this is you take broad consent from a group of patients. And then when your study comes out, you then randomize the patients and contact only the patients who are randomized to receive the intervention. And they can either accept or decline. And then the patients who are consented to be in the control arm will just fill in their data as normal. Now, this is great for popular, new and expensive interventions. In the deformity pathway, read VBT. So what we can do with this data is it relies on a pool of consented patients, but imagine you want to do a study on enhanced recovery. So all you would do is decide on the study. If all the patients are on there from the waiting list already, you can then just randomize them and do your study. And that's why quality of recovery is in there, because I think a lot of these cohort multiple RCTs will be done on patients who are around surgery. But we also want to encourage observational studies, because RCTs aren't very good for certain things. They're not good for painful conditions because there's too much crossover. They're not good for rare outcomes, rare diseases, and for long-term outcomes because they're too expensive. However, we've got problems with observational studies. We've got selection bias and we've got confounding bias. But we can account for those if we know the confounding variables. And there's a scoping review going on at the moment to identify all the confounding variables in pediatric spinal deformity surgery so that we can put these into the registry to collect. Observational studies, this is the template that we want to see. We want to see a scoping or a systematic review to demonstrate that you've got a research gap. so that you can work out your inclusion and exclusion criteria and your outcome measure, which will hopefully be one that we collect in the registry already. Then you can write a protocol, and that protocol will ideally link to the PSP. You'll get your patient public engagement, involvement engagement, and you'll have to justify your study design. Why are you not doing an RCT? And you may just want to do an observational study. Then you define your variables, and if we need more variables, we'll create an additional form for you. And then which centres? Who's going to do this? Is it just going to be 4 or 5 centres, or is it going to be national? And I'll finish now because I'm taking up more of my time. But this is a good example of where we can use observational studies, cohort studies, probability of an outcome, device monitoring, PROMs and PREMs development, rare diseases, and natural history studies, which I think Tim was alluding to. So get on board. We've got a good opportunity to change things, and we will be coming to lumbar degen and cervical degen very soon.
We're going to move straight on to Mike updating us on GIRFT. We'll take questions if we want to at the end.
Okay, I realise it's getting on in the day, and I'm going to try and whiz through some of this quite quickly, just to give you an update really about what's happening, and so that things don't take you from left field when they are. So the first thing is that we've already reviewed most of the independent sector with GIRFT spines and GIRFT orthopedics, and that currently, if you work in a Ramsey healthcare institution, then the GIRFT visits are beginning to go around there. I've got one this evening actually. So just to give you a heads up for that, it's the usual way things go about things, which is data pack and then a sit-down discussion with clinicians. The National Suspected Chord Equina Pathway. The QR code was updated yesterday, recognising that there's been some very minor changes. We try and respond to anyone that finds things amazing. It's like peer review all the time when people find things that are confusing, that we can then make it better and clarify it. If you look at the pathway, it's just been announced today that we've basically just under 20,000 people, clinicians, have actually used it. It's about £3,000 per month, so clearly some people do actually find it helpful to try and work out what's going on. So with that, we've also I've managed to find that actually every MR that gets undertaken in England is documented on a database. And there's different SNOMED codes. You can actually see where these MRs are undertaken. And when I first looked at it, there were some limitations in the data, like any data. You could see that a scan was, sort of requested for same day. That was the lowest, quickest sort of time frame. And that meant that, a patient might have been scanned within an hour if it gone from one night to the other. So this data is being updated and has started to be collected in October. So it will be time-stamped. So we'll actually know how long it takes to get an MRI scan. So we can monitor that, and there'll be a database coming out actually with a whole chord equina dashboard later on in the year, hopefully allowing you to look at your data and review your data. But you get a bit of an idea that MR requests have gone up across the board. You can see where they come from GPs, where they're done in EDs, etc. On the same note, we got contacted by the chord equina charities to say, look, your pathway, we like it, but NHS 111 don't seem to know anything about it, which was fair enough. So they were really helpful, actually. And it's a really interesting data source, this, NHS 111 data. And they have linked data from the telephone call all the way through to the admission and whether they were imaged and what their final diagnosis was, whether they had an operation. So they have this data all the way through, and they were happy to work with us. So we basically, to give you an idea of the number of calls, you can see at the top, to the left is 111s and 999 calls, but you can see the huge volume of calls that come through, and actually where they've actually been able to say it was a CES specific diagnosis through having gone through the pathway is fascinating. Spinal cord compression is there too. So what they were at the time was, if you got through it all on the telephone And they said, yeah, we think you've got caudal equina. At the time, it was a category 3 ambulance, which at that time was a 2-day wait for an ambulance, which seemed to be slightly about keeping what we were trying to say. So they've changed it all. And they've already recognised from their data that they've followed that there's been a massive, we've changed it, we've made it a more urgent ambulance and a more urgent clinical review, but also because the questions, you just wouldn't believe them. You know, you'd be sent up for having a urinary tract infection, left right side, it's caudal equina syndrome. So we've gone through that process because I don't think anyone from a spinal perspective had seen it. It was all very much primary care based. You can now on your NSIP data go into it and you can actually filter it by the caudal equina diagnosis code. If you're in your lumbar decompression, just get to me pathway, you can see, pick out those patients that had caudal equina and whether they've been coded properly or not. And ultimately, you can see if you use that code that caudal equina is associated with a longer length of stay, et cetera, and a higher emergency readmission rate, which is completely understandable, which sort of kind of fits what we thought. So, the next thing we're going to talk about quickly is the vertebral fragility fracture pathway. This was more of a trying to make something simpler, believe it or not, that's simpler than what we had, what another program had come out with. That's due to go live. We're waiting for BAS, who've been brilliant. They've sent back loads of comments. We've incorporated all the comments, so that's currently under BAS's review to be, for them to be happy with it before it gets put out there. In terms of this, you need to know about your interface services are subject to massive variation. This is just an example of the Northeast where they're completely on it. They know the waiting times for an urgent versus a routine for a spinal service, for surgical interface service. And I can normally tell if I go to a secondary care provider where they've got a functioning interface service. In this case, where the spinal interface service, this is the worst in England, has a 96-week wait to see, and you have to argue what is the point. That, you know, they were having the secondary care, 40% was sent for diagnostics, you know, that's in their first outpatient appointment. They were discharging 30-odd% in their first outpatient appointment. So massive variability in MSK care, and something that we're going to get onto. There have been some people appointed, but I don't know if anyone's seen the news just now. I'm not quite sure whether that appointments are going to stand, because it looks like NHS England's on the cancelled list. But the aim of this was to try and improve interface services, that they're working seamlessly and doing what they're supposed to do, which is direct patients into the right areas, treat ones that can be treated in the community, and hopefully aid you in your secondary care service. Some patients will always need to see us. So going on from there, we'll continue to, we've always asked to come and have a talk to networks and fighting about that. We are doing unit level reviews. It's at your request, yours or your management's request. So we don't go around saying, right, here you're having a review unless you ask us. There are some implant reporting going on in trust. There's about 7 million, even if you don't go down to the lowest price, there's about 7 million available if we just went to medium price available. NSIP is that I'll update you on in a second. And the point is that that's pretty much finished for spines. We're seen as some of the better specialties, because the log-ons, etc., are high. About 40% of us have logged on in the last 6 months. And so it's improving. It's a bit like the British Spine Registry, but I think it's great. I really find it very useful just to look at things in lots of different ways. So I advocate for you to do it. Now, there was a thing going on with NSIP where we know who's really good at it and who's looking at it at trust level, and so we're trying to get those to champion things a bit more locally. So I think the future, and who knows what the future holds, given the fact we've just had the announcement on BBC News, etc. We were planning to do a foot drop pathway, also some MSCC infection. We were already working on an AIS pathway. And lastly, Ashley and I have been talking about the best practice tariff. And he hasn't mentioned it. Am I allowed to mention it?
Yeah.
So we are working on compliance rate of greater than 80% to start from 2026. So it's going to be harder to get that money. So we may have to look at the data a bit and review how high that gets set. But that was always the plan, and COVID sort of stopped it happening. Thank you very much.
Right, I'll update about the spine ODEB beyond compliance. ORP has already been covered, and international spine registries, I think Ashley covered a little bit of that. these are my disclosures. So we've done cervical disc replacement. I think you've seen the slide in the previous debate and in Ashley's slides as well. So for cervical disc replacements, we use two important benchmarks, revision at the same level and adjacent segment disease. And this is how the rating is. Just a quick reminder, the number is the number of years, A star A, B is the number of proms that you've got linked in that cohort. So these are the discs that have been given ratings at this point. It's not something that is lifelong. You have to revisit this every 3 to 5 years. So that's the plan. So we have done this a couple of years ago, so this would be coming around again soon. Then we embarked on doing something for cervical for cages. And we thought we'll start with cervical cages, which would be an easier device to monitor because lumbar cages can be implanted in different modalities. But the difficulty we had, so we met last July, spent all day, came up with some benchmarks and ratings, and it all went down the loo virtually. I'm sorry to say that. And we've had multiple meetings since because ODEP does not rate fixed devices. All ODEP rates is mobile devices. Take a hip or a knee or an ankle or a shoulder or a CMC joint replacement. It is a joint replacement. So we have to make them learn or unlearn things, and we've really struggled hard. And eventually, on Tuesday when we met here, I know there's only a few people sitting there, but many of them were online. We've managed to crack something through. We've agreed on, so the rating's going to be different for fixed devices. So it'll be a rating based on bronze, silver, gold, platinum. So you could have a bronze A star. So if I go back to the rating system here, so rather than 3 A star, 5 A star, if you see on the top line, it'll be a bronze A star, silver A star. So that's going to come through. So hopefully the ODEP panel agree on it and allow us to do that. So hopefully later this year we'll be rating cervical cages, and that would be the first fixed device that ODEP would ever rate. Just briefly touch upon beyond compliance. I think we discussed this in BSS, but not in this forum. So beyond compliance is for, like ODEP is for legacy devices. Beyond compliance is for new devices. And, you know, we've been reactive. We come up with things after some thing happens and some catastrophe happens, and you go, we need to do something about it. So metal on metal hip, the hip resurfacing were the ones because of which beyond compliance was set up. And as you can see on the graph, if you see the red and blue line, it stays very similar to the yellow line in the first 2 years. And after that, you can see a significant change. So everybody who was implanting hips, the metal on metal hips, the resurfacing hips, was saying it's doing okay. But then a few stragglers started seeing things, discussions in the corridors, in the meetings, and then suddenly it blows up big time. And that is why beyond compliance was set up to monitor devices closely. So compliance is to get a CE mark or UK CA mark, but beyond that is why it was labeled as beyond compliance. And it's better that we do it rather than somebody else do it for us. So we had a meeting with one of the implant companies from a pediatric point of view, pediatric spine point of view. So we had a good initial meeting for beyond compliance with them, but we are awaiting the plan, how it's going to work. So the way it works is a few centers, champion surgeons, they continue to do the implantation. We as BC put some rapporteurs, some specialists we think who would work very well with them. And the data is collected on the registry. The registry provides the data every 6 monthly, and the panel meets up, the champion surgeons and the rapporteurs, and they go through the data to identify if there are any issues that are coming across with the device, including surgeons who are not doing things to the correct indication as well. So it's that specific at how the beyond compliance process works. So hopefully the work that we put in comes to fruition with the device that we've been working with. So once that comes through, then of course we'll share all that information with you as well. But to underpin it all, as Ashley mentioned, we need good data. So the International Spine Registry group was set up in March 2023. Jarkko from Finland is here. He's part of the group. And we're working on three main things: patient demographics, core outcome measures, and implant data. So we're just trying to harmonize that. So we are in touch with all the international spine registries that we know of, and we've reached out to them. So hopefully that'll be the minimum data set these registries will collect, which will harmonize data, make it easier for us to interpret, and for the companies as well from ODEB, BC, and MDR point of view. Thank you.
Thank you. Any questions?
Up here. Sachin, you showed a graph, sorry, Rajat Verma, you showed a graph which shows that for the hips, it was 2 years before things changed. And then you also had a graph that talks about vigilance. But if we are being encouraged to do things like, or early discharging of patients post-operatively and not keeping them under vigilance, those two seem a little bit contradictory.
I agree with you on that, because we have to have, like, maybe it's, so example for that would be, say if we were to introduce MAGIC again now, if it went through BC, you would be able to pick a lot of things up. Those patients you're not discharging. But if you're using a cervical cage, and we were talking about this, we will have to have mechanisms where there is review, because otherwise how are you going to collect that data and find out whether that cage is working or not, for example?
But if you're going to start then having cages also in there, that you're almost talking about almost all adult degen surgeries, they never get discharged.
No, I agree with you. And that was the point of debate, because ODEB wanted us to collect data for 10 years, 13 years, 15 years, because that's what they used to. And our point of view as surgeons was, at 2 years, if that segment is fused, what is the point of ongoing monitoring of that patient? There is no point, right? So that's the big discussion and debate we've had over the past year at least, and the number of meetings we've had, just gone back and forth. It's just been unbelievable. So,
thank you.
Great. Thank you.
Hi there, Anuj Bal from Hull, neurosurgeon. Just if you're going to increase the BPT to 80%, would you change the sort of time limit that we have to upload the information? You know, it's about a month or 3 months, pretty short sort of time frame to add all that data.
I'll say that. What, 3 months to fill in the procedure form in the BSR?
Well, from what I understand, at the end of the quarter, you have to sort of get compliance within a month of the end of the quarter.
Yes, you do. Yes.
Yeah.
So if you do an operation on the last day of the quarter, you've got a month to fill in the BSR procedure form.
Yeah, no, I'm just thinking, you know, you've got already people, lots of trusts with low compliance. That's just going to push even more people into lower compliance.
I don't think it'll push any more people into lower compliance. I think that, I mean, the compliance is, if it stays the same, it'll just mean more people fail the BPT. I mean, what we're looking to try and do is to get the surgeons in the room here to go back to their trusts and say, look, you're losing a lot of money. And if you give us a bit more support, then we can make that money back and we can make more than you lose. So that's the idea, really, so that hopefully we will improve compliance with that kind of a mechanism.
Thanks.
Hi, Himanshu.
Sorry, we're going to have to wrap it up now because there's a meeting starting in here. So very quick point.
Yeah. One question is, you know, in the BSR registry we don't have the adverse event reporting as accurate as we should have. And when we actually mention this to the patients, we usually underestimate, you know, the complication rate. Especially like adult deformity, 1.4%. Actually, it is 40 to 60%. Just for example, you know.
Yeah, I think you're right. I mean, if I'm looking to get measures on post-operative complications, I'd go to NSIP data, because at least it would give me revision operations, readmissions within 30 days, that kind of thing. Do you agree, Mike?
Yeah, I mean, I think that's a better resource because it captures everything as well. So you're dependent if a patient has a revision operation of the BSR that the other surgeon puts it in, but NSIP, it captures it. It just captures it automatically. And the last thing I would say is that there are other things that allow you to look at your complications. If a patient's gone in for a decompression and ended up in hospital for 20 days, I would suggest that they've had a problem of some sort, whatever it is. So you can very quickly look. That's why there's that funny length of stay greater than 6 days, because it filters your data right down quickly to these are the patients who had problems after discectomy.
Thanks to all speakers. Lunchtime.